Dr. Phillip Lee.
Thank you, Mr. Speaker. The title of this afternoon's debate, Managing Risk in the National Health Service, I think is very important. Indeed, the whole concept of risk and trying to understand what patients will accept in terms of risk is also possibly not for today, but it is a subject that we need to start considering, particularly in the light of the fact that everybody has access to information via the internet, and invariably the first thing you put into Google is the least likely thing that you're likely to be suffering from as a consequence of the symptoms that you're experiencing. And so therefore I think it's extremely important that risk is much more discussed with the patient population, because it's extremely difficult, as the member for Holborn and St Pancras mentioned earlier, it's extremely difficult to be a GP and try to manage the demands being placed upon the health service when people are coming in thinking that their headache is a brain tumour, for example. It's particularly appropriate that I'm speaking today because today CQC have released a report on Wexham and Heatherwood Trust. I'm surprised actually that the member for Slough hasn't taken the opportunity to speak in this debate as a consequence. It is a report that highlights some significant concerns about the trust, the care of patients. None of these concerns were news to me, I might add. It was something that I approached the then Secretary of State for Health about in June 2010, and I spoke to Monitor, who remarkably, the Chief Executive told me he had no concerns whatsoever and nothing had come across his radar about the trust. And I also spoke to Cynthia Bauer in September 2010 about it. I say that because those two organisations clearly were not fit for purpose in terms of doing their job of finding out what was wrong with hospitals. And I recognise the current Secretary of State's desire, and I support him wholeheartedly with the concept of the Chief Inspector of Hospitals. But I would counsel colleagues on both sides of the House that if we start looking properly at the performance of hospitals, judging by the list from of experiences that the member for Carnarvon Valley has just shared with the Chamber, we are going to have plenty more stories to deal with about hospitals and how they fail, or how they are failing. I want to concentrate primarily upon the legacy, I think, and the genesis of these problems, which, to be honest with you, probably blight both parties. I mean, a hospital doesn't suddenly become a problem in the space of a couple of years. It can be something that can occur over a number of decades. And the problem that we have in this country is the large number of our hospitals are not fit for purpose. There is a legacy of a poor location, because often land was bequeathed, but also the buildings are often not fit for purpose. That's a particular problem at Heatherwood with regards to the theatres, which was highlighted in the CQC report. There's a legacy also with regards to district general hospitals in general. District general hospitals have had their day. We really don't need them anymore. We need regional specialist hub hospitals, such as the one that I've been proposing for the Thames Valley for the last 3 to 4 years. And the reason I say that is that if you're trying to provide care, it's incredibly difficult to mitigate risk if your theatre is not fit for purpose, or if you cannot staff the hospital appropriately. And much has been made on the other side about nursing numbers. I mean, to be honest with you, it really is much bigger than that. It's actually to do with the quality of the clinicians. Most clinicians have to specialise and subspecialise. And the only way that you're going to be able to provide the very best care in the 21st century is by having fewer acute hospitals. All of the Royal Colleges share this opinion. This is not, I haven't got the corner on the market. The flip side, though, is that we're going to have more community hospitals and indeed more community care. And I think that can only be a good thing. And with reference to end-of-life care, I'd be cautious about all of this. If I was allow me to advise members, it's going to be extremely difficult to provide after end-of-life care in an increasingly ageing society. We're going to have some very, very difficult decisions to make for people in their 90s and for people over 100. There's no easy solution to this, and the Liverpool Care Pathway, I would suggest, was probably an honourable approach to try and take. I'm not saying it was perfect, but there was a desire to actually do the right thing in its implementation. But the reconfiguration is necessary, and for this reconfiguration to be appropriate, it's going to need cross-party support. We're not going to get anywhere by trading insults and trading sort of political positions over various hospitals. Quite a few hospitals aren't fit for purpose. Some of them are in Conservative seats, some of them are in Labour seats, some of them are in marginal seats. And if we really truly, those of us who are interested in this topic, if we really truly want to improve care for all, we really need to remove party politics from the reconfiguration debate and actually engage in a cross-party discussion about where these hospitals should be. Because if we did do that, if we did manage to build some new hospitals, because I suspect we will have to build quite a few, as I've said, the problem with a number of established hospitals is their locations are often inappropriate, certainly are in my part of the world. If we do engage in that debate, and if we can come to a consensus and some agreement on this, we really would be bequeathing to future generations a hospital sector to be proud of. We don't have one to be proud of. And with reference specifically to mortality rates that have been mentioned that have been going down, of course they've been going down. We're getting better at medicine. And with that comes problems and challenges with regards to end of life. Of course I'll give way.
Does the honourable member have any information on how Britain's lowering mortality rate compares with other countries, other European countries of comparable nature, to compare the rate at which ours is going down?
No, I don't to hand, but it would be interesting to compare mortality rates in various conditions with Germany, with Holland, with France over the last 7-10 years to see if they've also been seeing declining rates in those conditions. It would be very difficult, I think, just to say it's because of an investment of money in this country to claim that somehow that led to a reduced mortality rate. So I don't rule out that that might have been a factor, but I certainly suspect that it will have been because of advances in medicine and technology, and indeed within the skill base of consultants. Because fundamentally, if we do reconfigure, you're going to end up with consultants having a larger throughput of patients. And I think it's interesting to note that Tameside covers about 175,000 patients. Not enough. Basildon and Thurrock about 300 or so thousand, and Mid-Staff's about 225,000. These hospitals should be covering a minimum of 500,000, if not 750,000 people, if they're going to truly be able to deliver the very best acute and surgical care. And for the staff, particularly the consultants, they're going to want this throughput of patients so that they can maintain their skills and indeed enhance their skills and thereby improve mortality statistics. So in closing, I beg of both sides to take the party politics out of reconfiguration so that we can actually secure a hospital sector that we can be proud of for the next 5 decades.
Valerie